very large local susceptibility artifacts due to the strong positive magnetic susceptibility, especially when the metal is ferromagnetic. So some of the solutions use spin echo sequences instead of gradient echo. Utilize metal artifact reduction techniques. So again, this is available on all scanners, where you just have to increase your bandwidth, reduce your pixel size, and use a lower T as possible. And there are newly developed specific metal artifact reducing sequences. So you've got Maverick SL on GE, CMAC on your Siemens, and view angle tilting on your Philips. And these are specific sequences that have been developed to reduce the metal artifact. They are not to be confused with a metal artifact reduction technique, which is a technique as opposed to a sequence. Moving on to herringbone artifact. And it's called herringbone because it looks a bit like a pair of herringbone trousers, and it'll cover the entire image in a single slice or even in multiple slices. And it's caused by electronic spikes, by the gradient coils, fluctuating power supplies or RF pulse discrepancies, and therefore nothing you can do about this. Get in touch with your service engineer. Spike artifacts, these are quite extreme, but they're very similar to the herringbone, but they kind of show up as diamond-shaped patterns, and these are caused by electrostatic spikes, and it can be caused by one bad point of K-space from an electrostatic discharge. Again, there's nothing you can do about it. Consider repeating the scan. Okay, if the artifact remains, then your service personnel should be informed, because searching for these spikes or white pixels, as some people call them, is very time consuming and it's not very easy to reproduce. So get your friendly field engineer to help you out on that one. Okay, I'll just take a quick sip of water. So this will be our last set of artifacts, and these artifacts that emanate from the use of contrast agent. So the first one is due to contrast timing. Now, these are obviously radiographer fault, if you like, or radiographer blame. So this is where we need good teaching and good education on how to successfully manage these contrast enhanced examinations. So with a contrast agent timing, the timing of the bolus is crucial so that we get the maximum amount of arterial contrast, and we need to kind of tie this up with the acquisition of the central of the K-space data. So first of all, you need to explore what kind of K-space filling technique the sequence is set up, and then you need to then consider, when do I need my maximum, when will I get my maximum concentration of contrast to enable me to trigger this at the middle of the K-space acquisition. So have a look at your protocol, see what kind of technique you're using, and then use various timing mechanisms to calculate this. It's also essential that your contrast concentration doesn't change too rapidly during the acquisition. Otherwise, this will create a ringing artifact. So you need to make sure that you utilize a very nice tight bolus of contrast. Typically, you want to be using different. The timings will So so I'm trying to think how to put this. So depending on the kind of the anatomy that we're imaging, you want to make sure that the speed of the contrast ties in with the actual the anatomy. The wider, the bigger the vessel, then you need a much slower bolus rate compared to if you're using a carotid. If you're scanning a carotid artery, where you could utilize a slightly higher bolus rate. So in order to minimize this ringing artifact, the infusion should last for at least half the duration of the 3D image acquisition. So again, it's important that we don't use too fast a bolus, right? So we've got several techniques to help us achieve this peak of contrast timing. The best guess technique, so we estimate the travel time of the contrast agent based on the patient's age. I would strongly suggest that you avoid this technique because it doesn't work. Test bolus. We inject a small dose of contrast and use a fast 2D multi-phase scan to actually measure the travel time. By doing this, we can get ourselves a little graph and we can see exactly at what time point the maximum concentration of contrast arrives at the region of interest. Again, that's very old school. We've moved on since to possibly the automatic triggering, so the smart prep kind of technique, where we use a navigator echo to detect the arrival of the contrast agent at the location defined by the user. So all you do on this, you pop a little region of interest into the vessel where you want to define the location, and inject the contrast, and then the scanner will detect the arrival of the contrast due to a change in the MR signal, and it'll start your scan. Or the newer technique, so the fluoro trigger, the care bolus technique, if you wish, where we as operators initiate the scan when we actually see the contrast within the vessel in our region of interest. And I guess most people tend to use the fluoro trigger nowadays. So just a couple of examples. Left-hand image will show the contrast arriving too early, so therefore you've got some slight opacification of the periphery of the vessel, but there's no contrast at all within the middle. And obviously on the right-hand side this is supposed to be a carotid examination, but you can see that the contrast has basically exited the carotids, and it's gone all the way through the head, and it's coming down the jugular, it's coming down the sag sinus there. So again, that's way too late. So we're trying to avoid these kind of images if it's all possible. Now stents, again, there's nothing much you can do about this. But basically, it's signaling homogeneity, or if you wish, it's some kind of susceptibility artifact, because some of these stents will have metallic components to them, which helps with the actual strength of the stent. And because it's metal, obviously, it will give us a susceptibility artifact, and therefore a signal reduction. And this signal reduction can lead to a mistaken assumption that there might be a stenosis or occlusion within the stent, even if the blood flow is unrestricted. So you can probably see on the bottom right-hand image, it's more apparent where this patient has obviously got a femoral stent in place. There's absolutely no contrast within that region, but you can see that contrast is flowing freely, superior and inferior. So that image is due to a stent and not due to an occlusion. So one of the things that you can do is just consider increasing your flip angle within the sequence to increase the overall MRA signal, and it'll partially compensate for this kind of signal loss. And I think this is the final. Yeah, this is the final slide. So this is a T2 star artifact, and gadolinium-based contrast agents may have a signal cancelling effect, and this is called a T2 star effect or T2 star artifact. Now, you don't see this in all over the body, but the main location is in the upper subclavian artery, where you tend to get local signal cancellations occurring on the injection side within the MRA acquisition, and this can be misinterpreted as a stenosis or occlusion. You can also see this T2 star effect in non-MRA, where you get the sedimentation of the contrast agents within the bladder, and this will cause this kind of characteristic T2 star artifact. So you'd expect the urine in the bladder to be totally hyper intense, but due to this T2 star effect, you get this kind of half hyper intense, half hypo intense signal within the bladder. So as I said, it only typically occurs in contrast enhanced MRA, and you will only see it on the injection side. Okay, so basically what you should do, if the patient comes with any suspected pathology in maybe the right subclavian vein, subclavian artery, consider using the left arm as an injection site, and it'll eliminate this kind of false positive or false negative, if you like. Okay. And as I mentioned, that is the final slide. Now, a couple of the slides, I won't go through these. So these are